Hi, everyone, and welcome to the Clinics in Sports Medicine podcast. I'm Megan Ashdown, the managing editor for the series here at Elsevier. Today, we'll be discussing the July 2024 issue on precision ACL reconstruction, guest edited by Dr. Volker Musal and Dr. Al Getgood. Here now is a consulting editor, Dr. Winston Gwathmey, to lead the discussion.
My name is Winston Gwathmey from the University of Virginia. I'm the consulting editor for the Clinics in Sports Medicine. And so today we're very excited to have our podcast in Clinics in Sports Medicine to discuss the July 2024 issue. And we're very excited to talk about this topic. This issue is precision ACL reconstruction. I think that all of us who do sports medicine realize that the ACL reconstruction is always something we can do better. And this issue's got a lot of great tips and tidbits for us to do the best that we can in this area. So Volker and Al, thank you so much for being here. When you came up with this issue of precision ACL reconstruction, how did you put together the table of contents? Like, what do you think were important topics in 2024 for the surgeon who's doing ACL reconstruction? Can you kind of just go through the process of how you put this issue together?
Yeah, first of all, Vincent, thanks for inviting us to do this podcast. It's exciting. And I do remember, and I want to give a shout out to Mark Miller. Mark invited Freddie, this must be 15 or 20 years ago, to do something similar. And I was involved then as one of the people that wrote the article. And so asked us to do this new article and this new special theme issue on ACL. What I had in mind is sort of a little bit Freddie's legacy, a little bit Mark Miller's legacy, and then, just doing an update on what it all is these days. The ACL is not almost ever injured in isolation. So this special theme issue will talk about all the different items. Number one, of course, is the ACL. But then there are so many other issues around the ACL that when we talk about precision ACL, I think we want the reader to understand and maybe refresh how to essentially, number one goal should be avoid second ACL injury, right? So whether that is contralateral, ipsilateral second injury, it's disastrous for the young athlete. And by the way, when we're talking about ACL, I think we should also be talking about like the 25 and younger athletes. It's a whole different issue if we talk about 35-year-old athletes. No disrespect to anyone that's older than 35. But as far as ACL goes, you're in the golden zone if you're 30 plus. You have a very low risk of re-tearing. So that's not what we're talking about. When we go to meetings, we talk about this tunnel placement all the time, and people are getting sick of it. Nobody wants to talk about tunnel placement. But the issue is this, okay? Every fifth or every sixth ACL, you find a notch that's so tiny. You find a notch that's so curved in the back. And you find an ACL that's so scarred in the back that if you don't pay attention, if you're not precise about it, you will just misplace it. And it's key that 100% of the cases, they deserve that you do an appropriate tunnel placement. Whether it's the high AM or the central footprint, it just has to be within that footprint. And if you look at the table of contents, the other issues are, what about the lateral structures? We can talk about that in more detail. What about the meniscus root that tears very, very often, probably 20% of the time? So you have to look there and know what to do with it. What about the medial meniscus? And then the collateral structures. There's not just the anterolateral, there's also the anteromedial. And then later in the Clinics for Sports Medicine issue, we talk about osteotomy and other things. But so this is just a rough overview.
If I can maybe jump in as well and just say, Winston, is that with the table of contents, you've got different sections, right? And the journey of your ACL patient is you're going through this preoperative decision making, and that comes down to clinical examination. I mean, so often I hear people talk about MRI scans, and it's, it comes down to good clinical examination, making a good clinical decision, deciding when you should be operating on the patient. Some patients don't actually need surgery. We know that. Some patients do very well without an operation. So we need to try and understand how best to get across. Maybe that patient would do better without a procedure. And then you go into the surgery itself. It's not just about getting the tunnels right. It's about making decisions in and around all the other structures that are involved and all these other risk factors. So that sort of individualized risk assessment. And then, hopefully we do a good job in the surgery. And I think all of the, the chapters that have come out have really highlighted all those specific areas. But then you get into the post-operative side of things. How do we rehabilitate the patient? How do we actually evaluate their outcome? Did they do well? how should we be evaluating their outcomes? And I think that's really important to be thinking about pre, peri, and post-operative treatment of our patients.
I completely agree with Al as far as how you put it together as a journey. ACL surgery, the evaluation, the surgery, the post-operative treatment is a journey, and you experience that as a surgeon with your patient. And getting it right is so critical because you're looking at an athlete who's injured themselves and they've had their season taken from them, or maybe they're a college athlete and they might have a limited time when they actually can participate in their sport. It is so important to get it right. Because if you get it wrong, they might lose 2 seasons or 3 seasons and never have the same need. The best possible time to get it right is the first time. There's no question in my mind. So we've got 15 great chapters in this. We're going to go through the entire preoperative, perioperative, and postoperative sort of experience of the ACL reconstruction. And I think the key thing here, and I think Dr. Freddie Fu taught us how important this is, the anatomic ACL. And I think, Volker, you're in a pretty good position to kind of talk about that. And what does that mean to you? Define the anatomic ACL.
That you connect the ACL and the femur and tibia in the anatomic center, footprint. But it means more than that. It means, take care of the whole knee, the menisci, and all the other risk factors that particular individual may have. That's what this special theme issue is talking about.
Yeah, very good. I think that's really important. I think, again, Dr. Fu is obviously a legend when it comes to helping us understand the injury process and kind of what goes on with ACL injury. And putting the tunnels in the right position and all that is obviously critical to that. So I guess, Al, I could ask you that. How would you define precision tunnel placement? Like, how would you define that in your practice?
Yeah, it's always challenging because how many times you've been to a meeting where every time we talk about tunnel placement, right? You'd think, that by now we'd have worked out exactly where to place our tunnels. And I think Freddie has got to be credited with really making us understand the anatomy of the ACL, both in its femoral and tibial tunnel positions. But then, when we start looking at our clinical results, and if you look at sort of the evolution of arthroscopic ACL reconstruction, we went through this sort of a high AM position, whether you want to call that over the top, whatever you want to call that, to then bringing it, back down into that mid-bundle tunnel position. And unfortunately, our clinical results really didn't replicate, didn't really reconstitute the results that we were looking for. And so, with multiple studies coming from UK, Andy Williams, Tim Spalding, and then also New Zealand registry, we can see that the results maybe we should be pushing our tunnels back into a slightly more AM position. So thinking more about the kinematics of the knee. So it's still very much thinking about the anatomy. We don't want to be outside of the footprint, but maybe actually being in a more kinematically beneficial position in a slightly more AM position is beneficial.
So with that in mind, Al, if I could ask you, Chapter 5, or in this is avoiding graft failure, lessons learned from the stability trial. Now, not going into too much detail, can you kind of give us just a couple of things you might have learned from that trial as far as what led you to see graft failures?
I think sometimes everyone wants to focus on the lateral structures and the lateral tenodesis. And of course, the lateral tenodesis was very effective in this particular trial. I think the most important lesson that we learned from this study has been the need to focus on an at-risk population, right? So, I think previous studies, and if you look at all the meta-analyses that were done up until sort of 2015, whatever, they were really looked at an average age of patients 27 to 29, a varying degree of activity level. And really we know from lots and lots of studies that our at-risk patients are our younger athletes. And so if you separate out your at-risk patients, you really look at your younger athletes, and then you can start going down through the risk factors associated with them. And so you'll hear us talk about this over and over again. Is this individualized risk assessment? It's that we're not looking at big averages across multiple populations. It's really saying, what's your patient in front of you? What risks do they have? Do they have generalized ligamentous laxity? Do they have an issue with high-grade pivot shift, high-grade laxity? Are they going back to an at-risk sport, soccer, for example, football, rugby? And are they under the age of 25, and even more so under the age of 20? Can you look at bony morphology, slope, and all these other issues? Then you can really drill down into this patient population that needs something else other than just your standard ACL reconstruction. And what we're really trying to say is, precision ACL. Let's get away from just being, I'm a hamstring tendon autograft ACL surgeon, or I'm a BTB autograft ACL reconstruction surgeon. No, we're ACL surgeons, we're knee surgeons, and we tailor our surgery to that specific patient and addressing those specific risk factors to try and optimize outcome. And that's really what we try and tease out in that particular chapter, particularly focusing on the data from the stability trial, which is, we've all over multiple papers, we've looked at predictors, we've looked at a number of different things. And I think hopefully the readers will take from, it's a synopsis of 10 years work from the stability study that hopefully will help benefit the patient in their practice.
So great. Yeah, you mentioned a lot about the risk factors and things like that. And again, everyone we treat is a little bit different. Let's kind of just go through a couple of different scenarios. I mean, so Volker, in your practice, you have a 15-year-old athlete, high school athlete, soccer player, let's call her a female soccer player with a little bit of ligamentous laxity, normal slope. What's your preferred graft technique, and just what's your thought process going into that, and how should surgeons be looking at that patient?
You're asking me a very hard question, but that's good, because this is probably the most pertinent question also. That 15-year-old, assuming skeletal maturity, you have a variety of graft choices: quadriceps, patellar tendon, hamstring tendon, no allograft. So 3 choices, and maybe contralateral. And so, I mean, currently, obviously, you don't want to hear that, but that patient gets offered the trial, which is stability 2. We all really believe that between quadriceps and patellar tendon, there is not a difference that we currently know of. Now, when the study is done, we may not. And the big question then is, lateral tenodesis. And we just really don't know, if they have a slightly higher slope and you're talking hamstring. Al's study has showed that, after 9 degrees, I think you ought to go. In fact, you better, with hamstring, you should think twice doing a hamstring autograft without anything else. You really should think about that twice. The data is quite overwhelming, and Al can chime in on this since it's your work, and the French work, the British work, it's so many, New Zealand.
Yeah, I mean, it's hard to answer that question, obviously. But yeah, Al, what do you want to chime in?
I think number one, no allograft, right? And I think, Moon has shown that. And it's been nice to see that I think the trend of allograft in young patients is definitely decreasing. So that's great. Hamstring tendon is still the most common graft utilized worldwide. And we've seen that in, ISACOS surveys and various other surveys. But really the evidence is fairly overwhelming that we should not be using a hamstring graft in isolation in a young athlete. That's been shown in registry studies, whether it's the New Zealand registry, Danish registry, Norwegian registry, Kaiser Permanente. We've shown it in stability 2, 11% failure, stability 1, 11% failure rate, isolated hamstring versus 4% if you add in a lateral tenodesis. Nick Wattati's study from Calgary, a significant reduction in failure if using a patella tendon versus a hamstring tendon. So it's just getting to the point now that, it doesn't mean to say that a hamstring graft is a bad graft. It's just not the optimal graft for a 15-year-old kid that you're talking about who's going to go back to sport. And, they might get lucky. We know 90% of patients do pretty well with a hamstring graft. We just can't very easily predict who's going to do badly. So for me, now sitting in front of a patient who's 15 years old, I'm just not going to offer them an isolated hamstring graft. I don't have equipoise. I do have equipoise when it comes to thinking about a quadricep tendon or a patella tendon. And I also think, should we maybe add a lateral tenodesis? But hamstring grafts are completely off the table for me now in that patient population.
Yeah, it's interesting you say that. I did my traveling fellowship in Southeast Asia. I went to Korea, went to Japan, and hamstring was by far the number one graft they were using. In fact, patella tendon was almost, we didn't talk about it hardly at all. It was almost a graft we didn't harvest out there in Southeast Asia. So you can certainly see kind of what the different trends worldwide are for that. But I mean, when I was in training in 2007 to 2012, hamstring was the number one graft we used in my training. And then in my practice, I hardly ever see it, or I hardly ever use it. But quadriceps is definitely the new kid in the block. And it's good to see that it's showing evidence of being an equivalent graft, because I think certainly it's nice to have an armamentarium. Let's switch patients here. So let's talk about an older patient, let's say in his 50s, maybe a biking enthusiast. And let's say that he's torn his ACL. What would would you think of Alan, he comes to your clinic? What would you do in an older athlete, if you would call it that?
Well, I mean, I think, let's go back to our, the early phase and say, well, here's your preoperative decision making. And we do know that there's a lot of patients that don't have significant risk factors. They don't have other, significant pathology. Many patients with a good rehabilitation program, so a good neuromuscular training program, will do very well without an ACL reconstruction, right? And so, I think that's the first thing you can have that conversation with, and that's why we bring in, the preoperative treatment of non-operative ACL injury. It's a very relevant thing to discuss with your patients, and you can give it a go, and you can see how that works out. I work in it's a good system in many ways in Canada, because we do have a slightly longer waiting list than maybe you would have in the US. And you can use that to your advantage, so that if there are certain patients that actually may, probably benefit from non-operative treatment, you can still put them on the waiting list, give them a rehab program. Many patients will actually drop off the waiting list, not needing surgery, because they find that they're coping very, very well. And so that, that's a good thing. And, ACL reconstruction is, as much as we would like to think it's a great operation, it still has its problems. It's still not perfect. And so I think if you can get away without an operation, it's not a bad thing. Of course, Volker, being the athlete that he is, he's probably, well, that's a conversation that we're going to have, and ultimately, it comes down to, an individualized risk assessment, a discussion, it's shared decision making. Some patients just want to have their ACL fixed, and I totally understand that. In which case, then, then in terms of graft choice, the good news is, and I think Volker already mentioned it, is that the risk of re-injury, when you're in your late 40s, 50s, the risk of re-injury is low, in which case then it's pretty much dealer's choice. You can have what you want, really.
Yeah, maybe an interesting addition to this too is, right, obviously in the US we use a lot of allograft. I know you probably do the same, Winston. In Europe, you don't. So for those of you that listen from Asia, Europe, other countries, allograft is not maybe so readily available. Now, what do you do? And I think any graft is fine. But an interesting study that was presented from the Innsbruck group from Christian Finkenhauser at the ACL study group just recently is on quadriceps tendon in that older athlete, the cyclist you just mentioned. They often have enthesiophytes and sort of changes at the quadriceps insertion on the patella. If those are really severe changes in tears, if you will, you probably can't use that graft. But in the absence of that, they showed very comparable outcome using quadriceps autograft in that particular patient population, which I think is a good graft choice.
So Volker, you talk about patella and quadriceps being equivalent. What's your number one? What's your 1A, or what's your number? Like, is there a reason why you wouldn't use patella tendon, or a reason why you wouldn't use quad? You just talked about endosopathy, but what about Osgood-Schlatter lesions or anything else like that, tendinopathies?
That's right. So patella tendon in somebody that is a young basketball player that already has a diagnosis of jumper's knee, and you actually see changes on the MRI. If they have jumper's knee without MRI changes, I don't really care. But if they have like a torn up, insertion of the patella tendon on the patella, even without a quadriceps lag, I probably wouldn't like to use that graft. And there's some evidence too that was presented at one of the recent ISACOS meetings. And by the same token, an Osgood-Schlatter, I probably wouldn't harvest that either. But a skeletal sheet, mature, 18-year-old quadriceps and patella is dealer's choice. The quadriceps will get, slightly more anterior knee pain, possibly. But if you harvest it well and fill it back with bone that you harvest from your tibial tunnel, you can probably mitigate that. And the quadriceps, you have an extra incision. If it's a really thick leg, it's maybe a bit more tricky to harvest that. And one thing that we didn't talk about, we talk about probably in chapter 11 and below, PTOA, right? So post-traumatic arthritis, you get with patella tendon more than with hamstring. So quadriceps is not really known yet. People think so, but nobody's showed us this data. You can't say that. And we're currently looking at Freddie Fu's 10-year double bundle outcome study. So hopefully in a year from now, we'll give you some data.
So what about ACL repair? Chapter 9 is an ACL repair. Where are we with that in 2024?
There are certainly scenarios where I think ACL repair has a role. I often say to my fellows that, never say never, never say always. The evidence would suggest is that we shouldn't be doing ACL repair in the young athletes. The at-risk patients, the failure rates are just too high, right? And it kind of kills me when I see lots and lots of people trying to advocate and then market ACL repair in the younger patient population when the failure rates are higher, and we can maybe talk about that when it comes to evaluation of outcomes. Where the studies show equivalence or maybe some benefits are in older patients. And the challenge, I guess, that I have in this scenario is, go back to our previous discussion about non-operative treatment is, many of the older patients will actually do very well with non-operative management. And particularly with the femoral peel-offs, the Sherman 1s, Sherman 2s, I think you've got an opportunity there for a healing response, but they're also the ideal patients to repair. So, that's, again, a conversation that you have with your patient. And, I think if I was going to start doing ACL repair, those would be the ones I'd be targeting. But equally, they're the ones that I try and really advocate for non-operative treatment. So I think that's where the challenge is. Where I do ACL repair is more in my multi-ligament reconstruction. So where I'm doing acute reconstruction, and it's clearly, a very decent bit of tissue. And it's not very often, but I will occasionally and have got some very good outcomes in the multi-ligament knee by doing an ACL repair.
I always like talking to experienced ACL surgeons and kind of talk about the evolution of their experience. What are you doing now in 2024 that you weren't doing in 2014, 10 years ago, Volker? Or what are you doing more often, I guess you could say now?
That's a great question. So first of all, I'm looking at the MRI with a very different eye. The slope looked at me in 2014, but I did not look at it. Now that's X-ray. You shouldn't do that on MRI. In chapter 10, we mentioned, so 10 is about revision ACL. We mentioned a very interesting thing. So you get this gestalt look on an MRI where sometimes a little bit hard to describe, but you can see the indented sulcus, the steep slope, the tiny, lateral plateau, the elongated condyle. And we put this together, Sahil Dadu, the lead author in chapter 10. If the intermeniscal distance is beyond a certain threshold low, they have much higher risk for high-grade pivot shift. So that's one thing I do different. I look at the pre-op imaging differently about risk factors and, of course, concomitant lesions. Another thing I do differently is, I did in 2014 already, but not as much. I always switch portals. I don't ever drill my femoral tunnel, without having looked at from the medial side. And again, I switch back and forth probably 5 times and make sure I am truly precisely in the back there. Another thing I do different is I use quad tendon. In 2014, I did very few of those, and I'm very comfortable with it now, and I know what to avoid and what to do right. And another thing I do different is, if I do hamstrings, which I don't, I do a lateral tenodesis always. And in revisions, I use frequently lateral tenodesis, not always, but frequently. So those are some of my pearls.
Yeah, I guess in 2014, I was probably doing 80-90% hamstring grafts. At that time, randomizing to whether or not I would add a lateral tenodesis. And, jump 10 years forward, I'm now not really doing any hamstring grafts. And I'm doing an extensor mechanism graft, and funnily enough, still randomizing lateral tenodesis. Ultimately, I very rarely do a hamstring graft anymore, and it's a tough one for me. And I think that the results have been in my hands have been much better, and the data has been really showing to be better with an extensor mechanism graft. And the big thing has been whether or not I've moved away from doing as many lateral tenodesis with patella tendons and quadricep tendons, doing more now because of stability too. The big question will be whether or not you need to add in the lateral tenodesis into an extensor mechanism graft, and hopefully with stability too, that'll sort of tease that out. Whereas the hamstring grafts, clearly we had to do more. I'd say 2014, I was doing root repairs. I probably was just starting to understand a bit more about ramp lesions, certainly being, very much focused on meniscal preservation. So not a huge difference on the meniscus side of things. And tunnel position, probably moved from at that time doing more of a sort of a mid bundle and moved back to a slightly higher AM position.
Winston, if I can add maybe 2 other things that just came to my mind that I've learned over these 10 years is One, we all have become part of big multi-center networks. Many of us have, and they're really, really driving our science. So our stability network is huge, and not just the science that comes from it, but also the bi-weekly meetings in which we all exchange and learn from another. We collect complications and teach each other how to avoid them. And the other thing that in 2014 I did not know how to do is how to randomize a patient. It's actually not that hard. You got to learn that. I think in this day and age, we all should be able to do these types of studies. So we're really excited that we will be able to contribute.
What I want to ask you, you brought up stability several times and stability two. Can you just go ahead and tell the listener what exactly stability is and how you're enrolling patients?
Sure. I mean, Stability originally was Stability 1 was essentially a randomized clinical trial. It was a 9-center, multi-center RCT comparing ACL reconstruction with hamstring tendon autograft with or without the addition of a modified lamellar lateral tenodesis. We focused on young patients under the age of 25 going back to sport. They also had to have some other risk factors, high-grade pivot, hyperextension, or generalized ligamentous laxity. So really focusing on high-risk patients and risk of re-injury. And then over 2 years, we followed them up to see what their outcome was with a primary outcome of asymmetric rotatory laxity or graft failure. And we showed that with the lateral tenodesis, it had a statistically significant, clinically significant reduction in persistent rotatory laxity as well as graft failure. And so, that was a big study. We sort of, it was 618 patients, probably the largest RCT that's been done in ACL reconstruction. In many ways, it's really brought forward the use of lateral tenodesis and ACL reconstruction, which has been great. But there were a lot of unanswered questions, particularly surrounding the concern of whether or not, is a hamstring tendon autograft. Well, what about all of, particularly in the US population, who are very much more predominantly patella tendon, but more increasingly a quadricep tendon autograft? What could you do there? And so Stability 2 has been really the success story off the back of Stability 1. Stability 1 was ISACOS funded, and it was an amazing achievement from all of the centers that were involved in Stability 1 with relatively small amount of funding. But, you can look at that as being seed funding. And we were able to then collaborate with Volker and Jay Ergang at Pitt and went after both Canadian Institute of Health Research as well as National Institute of Health Research, so NIH funding. With the seed funding from, and the track record of Stability 1, then we could get some really a significant grant to be able to then now build Stability 2, which is now a 30-center, multi-center randomized clinical trial. We'll be comparing patella tendon plus quadricep tendon with or without lateral tenodesis, so 1,236 patients, so essentially doubling the numbers. But with that, our outcomes, our secondary outcomes are so much greater because we've got a little bit more money to understand a little bit about what's going on. And, ultimately by the end of this trial, because we're using the same inclusion-exclusion criteria, we will have 1,800 patients, all under the age of 25, free grafts with or without tenodesis. And we can hopefully then really start to tease out when we should be using these specific graft and graft LDT type combinations. And that really speaks an awful lot to precision ACL. I mean, we don't have the answers right now, but we really hope in 2027, 2028, when we finish the trial and we've got the outcomes, that we can really tease this out. And we can sit with that 15-year-old patient, and instead of us giving our thoughts of what it is, we can have a data-driven conversation. And that is going to be the Stability legacy. And it's exciting. And, we've got a huge number of people involved, and, it's great to be working with Volker on this.
We've been talking a lot about lateral extra-articular tenodesis on this podcast. And one thing I didn't do in 2014 that I do now is lateral extra-articular tenodesis. And LET back in 14, at least in Virginia, was something we didn't really even talk about that much. And now we're talking about it all the time. So Volker, maybe you can help me understand, there are a lot of lateral procedures you can do. What does LET in your hands look like?
So LET, by definition, whichever technique you use is a non-anatomic technique, but there is no degradation or anything like that. It just, so is Latarjet in the shoulder, but it's a technique that, can help stabilize. And so the way I explain it to the patient is, we stabilize around the posterior capsule and tighten it up. There are so many different techniques. Most commonly, and in the Stability trial, we all use the same technique. We kind of taught each other and had a course together, what's called the modified Lemire. And so just maybe real briefly, in that technique, it's a 1-inch incision over the posterior IT band at the level of the lateral epicondyle. The posterior part of the IT band remains intact, and then we harvest like 8 to 10 millimeter thick, about 6 to 8 centimeters long of a graft that remains attached like Gertie's tubercle. And we pass it deep to the LCL and fix it right at the metadiaphyseal flare, which the London group with Andrew Amos and Andy Williams had shown sort of an array of isometric points that are proximal to the LCL. Now, this is a construct that, if done alone, like back in the 70s, it won't work. The central pivot is still the key, and it both doesn't work as well as over-constrains and gives arthritis. But the modern technique does not, and Bertrand Sanricote has done the most research in this field of anyone, really, both with a number of patients as well as a number of papers. And he's showed this in hundreds and thousands of patients, and also has recently shown that there's no increased lateral OA. However, an interesting point to me is, and we've shown this with our technique, nobody else has shown it or disproved it, that after a year, this whole construct stretches out. That's really when it becomes interesting. That's how, at least how I recall it, how you called me after Stability 1 and said, wait a minute, this is interesting stuff. I think we need to go further here. Stability 1 is not the end all be all. And so this is interesting. So I challenge you, next time you see a failed ACL where you've already done the tenodesis, but the ACL failed anyway, which sometimes happens, show me that the lateral tenodesis actually failed. Nobody's showed me that yet. So maybe when you listen to this podcast, you see it, show me your case, publish it.
Taking a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
You mentioned that by definition, it's not anatomic. Well, how do you know where to attach it? Intraoperatively, do you use fluoro? Do you just use landmarks? Like, how do you know?
Well, if you go deep to the LCL, then your attachment will then be proximal, right? When you route it deep to the LCL, so now your point is proximal. Now, you can use fluoro. I'm not so sure how important it is that you get it in exactly the same spot every time. There's actually little research on this. But you got to stay low, posterior. You got to stay posterior and proximal. And you can feel when you do this tenodesis, you just put your index finger and you feel as the metaphysis becomes diaphysis, and this flare, that's where the staple goes. Yes, you can use fluoro and you can use many different ways how to fix it, but I wouldn't overthink it, to be honest. What do you think, Al?
The beauty of it going under the lateral collateral is it's much more forgiving. I guess I go back to 2013-14, and at the same time, the ACL Reconstruction was coming in as well. And we wanted to do something that was really simple. If it was going to work, we wanted to make sure that it was going to be translatable into multiple of the healthcare systems, multiple surgeons' hands, but do something that's relatively straightforward. And I think that's where the LET comes into its own. It's very, very straightforward. And, by bringing it under the LCL, you can put it in that metadiaphyseal region. You can actually make it even bigger incision. You can go even more proximal, but as long as you're hugging the posterior cortex, that's been shown out of Andrew Amos's lab that the length change characteristics are actually fairly similar. You're actually doing well. If you don't go underneath the lateral collateral ligament, you have to be much more precise about a so-called isometric point. It's not really isometric, and Bertrand has shown that with his reconstruction. You just have to be a little bit more precise about what you're doing. And if you get it wrong, you can run into problems. So that's why we like to do an open incision underneath the lateral collateral, very straightforward.
So is there a downside of doing an LET? And if not, why not just do it in everybody?
If you do it right, you probably won't create osteoarthritis, so that's good. So your downside would be, you make an additional incision, not a big deal, and you may have a fixation issue. Many people don't like the staple. I can tell you the staple doesn't give a lot of hardware issues. It's a good question, You could probably use it on everyone. But I think the main thing you need to remember is the lateral side, you may do whatever you want there. The most important thing is that the ACL gets restored, whichever way you do it, and whatever graft you use, in an appropriate anatomic, precise way. Otherwise, none of the lateral stuff will matter.
We know, I mean, and again, data drives our conversations, right? So we know it hurts more. So certainly in the first 3 months, patients complain of more pain. We also know that it takes a little bit longer for people to regain their quad strength. So there is morbidity associated with that extra incision. It takes longer in surgery, so it's an extra 15, 20 minutes, depending how facile you are with the procedure. It costs a little bit more depending on your implant of choice. Now, depending on your healthcare system and your reimbursement, then it may not, I can't imagine that's going to kill you in the United States, but in other parts of the world, it might. So there are some downsides to it. The bigger downsides are going to be the potential. Everyone is very head up about over constraint, what that does with post-traumatic OA. We've shown now that we just published a couple of studies now looking at quantitative MRI in the lateral compartment that there's very little difference. There is some difference with increased relaxation times in the anterior aspect of the lateral compartment. Now that may just correspond with the fact that we just have different loading contact points, and that's at 2 years. So we need to follow it up over a longer period of time. No difference in the patellofemoral joint. But our 7-year outcomes out of stability, when we're just looking at the Fallow-Kennedy patients, we're not seeing any difference in post-traumatic OA on radiographic evidence of OA. There's a paper from Lyon by Castaldi that highlighted this increased risk of lateral compartment osteoarthritis. The devil's in the detail with this paper, because it was the lateral tenodesis was actually a gracilis tendon that was incorporated into a patella tendon autograft that was then tunneled deep to the fibular collateral ligament. So I would argue it's a very different construct than what we're using with the IT band. And as Volker said, I think the IT band tends to stretch out a little bit. I'm not sure gracilis is going to stretch out as much. So, ultimately, we have to follow these patients for a longer period of time. Would I want to do it on every single patient on a routine basis? No, because there's morbidity associated with it. And I want to be in a position where I can really advocate for it in a specific indications.
I agree. And the Castaldi paper that you mentioned is obviously a very sort of old school kind of paper. It's, 20-year outcomes. So obviously it's done more than 20 years ago. And, the other interesting thing, going back to the study that we did showing that it stretches out after a year, Winston, it kind of loses its effect. The big question is, maybe in the beginning with the increased pain and the increased quadriceps weakness, does it maybe slow down the rehab progress? So that's something we need to research further.
We've been talking a lot about clinical trials and studies and whatnot. And Al, maybe you can help me out with this. Do you see any downsides with patient-reported outcomes in the assessment of ACL reconstruction?
Yeah, it's a huge area of focus that we have in our group. And if you look at chapter 12, and I don't want to spoil it for anybody who's reading that, but Hannah Marmura is the first author, and Diane Brandt is the co-PI on Stability 1 and Stability 2 with me. And is an absolute incredible, clinical methodologist, clinical trials methodologist. And, if you look at, let's say, if you take Stability 1, right, and our primary outcome of Stability 1 was a change in failure rates and rotatory laxity. And we saw significant differences, okay? And that really had an impact on changing practice around the world. Now, if you look at patient-reported outcomes, there's no difference between groups. If we had have chosen the patient-reported outcome as our primary outcome, we probably wouldn't have had as big an impact. And there are multiple studies that have used patient-reported outcomes as their primary outcome of choice and have not shown a benefit with a specific intervention, and therefore that intervention has disappeared. That is actually quite troubling, right? Because ultimately, what we're now focusing on is, well, what happens with patient-reported outcomes? What happens over time? And we look at this time period of, baseline pre-injury to 2 years post-operatively. But if you look at all the registry studies, you can never differentiate between anything in the registry studies at 2 years and 6 years. They're all doing very well with KOOS and IKDC. And it's ultimately because even if you're not doing the same stuff as that you were doing pre-injury, people adapt, right? It's this concept called response shift, where they adapt, they conceptualize as to what's going on in their life. Soccer may have been a big thing for them, at the time they hurt their ACL, but they've had an ACL reconstruction, and all of a sudden they say, well, you know what, soccer's not that important to me anymore. And actually, I've just finished university, and I'm in law school, and I need to focus really on my career. And soccer's not that important anymore. But actually, when you look at their KOOS score, you look at their IKDC, particularly KOOS is a particularly bad one because it's got such high ceiling. The ceiling effect is crazy. It's a low ceiling effect that really the patients, just questions that are asked are really not relevant to them as an athlete, and that's the challenge that we run into. And so we just see across the board patients doing very well. Now, if we focus on their stability one outcomes, if we just compare the two patient groups, there's no difference. When we actually focus on the patients who do badly, who had an adverse event, or if they had a re-injury, they actually score lower. But because the numbers of patients that are actually having those adverse events are actually quite low, they get washed out completely by all the other patients that are doing very well. So I think as a community, we need to start rethinking how we assess our outcomes and what's important to our patients. And so in short, I don't think patient-reported outcomes are the way forward.
Well, this has been outstanding. I think I have one last question I want to ask both of you. We talked about 2014 and what you were doing back then versus 2024. What do you see us doing in 2034? Where do you think we're going with all of this?
I mean, obviously, our studies, at least the current one, Stability 2, will be done. And I think we'll have a lot of data that will tell us really for each individual patient, boy, girl, woman, man, what sport they do and what their risk factors are. And here's probably the best graft choice and combination of choices. I think we will really be able to say that, and we can say with conviction. We have data, we have science behind it. I don't think we need to do all these consensus types of groups all the time, because we will have so much data at that point that, you either believe in the data or you don't. Right now we're doing all these consensus because data is lacking. So I think that's one thing. As far as surgery goes, I'm sure we go back and forth like we always do. The pendulum swings this way, it swings that way. Right now we're doing, more and more osteotomies. I don't think we're going to get too crazy with that. It's become an answer, though, for the multiple failed ACLs. So I think that will stay. We didn't mention Christian Latterman's work from chapter 13. I think Christian and many others will help drive this further forward. So I think there may be some biologics or other adjuvants we can maybe use during surgery, can maybe give us 1% or 2% of less failure. I think that's for sure. We didn't talk at all about AI, about machine learning, and about what all the, different augmented realities and all this. I think in 2034, many of us, certainly you in Virginia, you have such a beautiful new outpatient surgical center there. You'll have the smart OR, and you have all kinds of special glasses and augmented stuff, and hopefully overlay the images so that tunnel placement is easier, that your insertion point of the lateral lemma is easier. I think all that stuff will be there. And I think at that time, we probably need to make sure that our residents still know the old school, because what do you do when all that fails and you're like with your glasses and they shut down and all this? Anyway, it's just some of my thoughts. Al, do you have anything else? I mean, it's like, wow, so much. It'll be exciting. Lots of technology.
Technology will push faster than the biology. And so technological advances will be number one. I think we'll be doing something, the surgery, I think will be very, very similar. I'd love to be able to say we're going to be using tissue engineered grafts. We've been talking about that for decades, and we're nowhere any closer. So I don't think that's going to happen just at the moment. But I think the surgery will be very similar, but it'll just be technologically advanced. I really hope we will be making strides forward, is exactly what Volker said, is looking at the biology, particularly regarding post-traumatic OA, because there are things that we can use that won't take a huge amount of regulatory approval to be able to use it in the ACL injured knee, and whether or not that will show some promise to try and reducing the burden of OA. Because to me, I'm hoping Stability 2 will answer some of this stuff about graft choice and stability and stuff like that. But really, the next big question is going to be degenerative change afterwards.
Outstanding. This has been fantastic, guys. I really appreciate your contributions here. I'm looking forward to this issue of clinics and sports medicine. I think it's going to really help all of us who are trying to understand how to better treat these patients, really give them the best possible chance to get it right the first time. Because again, ultimately what we're trying to think about here, doing all this research, is just getting it right for our patients. And so thank you, Volker. Thank you, Al, for all you've done for ACL research and for this issue.
Thank you for joining us for the very first episode of our Clinics in Sports Medicine podcast. For an exclusive discount on the issue we discussed today, focusing on precision ACL reconstruction, visit us.elsevierhealth.com/expert. Clinics in Sports Medicine is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit theclinics.com. Be sure to follow us on Twitter and subscribe to the Clinics in Sports Medicine podcast wherever you get your podcasts.